Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings. I am pleased to welcome you to the multimedia summary for the journal's November 2022 issue. There are 3 articles that have been selected as our editor's choice or highlights articles this month. The editor's choice is an original article entitled Plant-Based Diets, an all-cause and cardiovascular mortality in a nationwide cohort in Spain, the ENRICA study. It is authored by Dr. Delgado Velandia from the School of Medicine, Universidad Autónoma de Madrid in Madrid, Spain, and colleagues from several Spanish institutions and the Harvard T.H. Chan School of Public Health in Boston, Massachusetts. Diets are broadly classified into animal-derived and plant-based foods, and substantial and mounting epidemiologic evidence indicates that consumption of the latter, compared with the former, is associated with health benefits and lowered mortality. But do all plant-derived dietary constituents uniformly and unerringly confer such health benefits? Delgado Velandia et al. Addressed this question in a study involving almost 12,000 individuals, broadly representative of the adult Spanish population, and who were followed for approximately 10 years after recruitment between 2008 and 2010. These individuals were participants in the prospective cohort study on nutrition and cardiovascular risk in Spain, the so-called ENRICA study. To assess the effects of the consumption of plant-based diets, the authors used a previously introduced distinction between healthy plant-based diets, for example, vegetables, fruits, whole grains, legumes, and unhealthy plant-based diets, for example, refined grains, potatoes, fruit juices, sugar, and beverages. Dietary intake was assessed by a validated diet history, and based on 18 major food groups, scores were obtained for a healthy plant-based diet or an unhealthy plant-based diet. The data demonstrate that all-cause mortality and cardiovascular-related mortality were decreased by 14% and 37% respectively for each 10-point increase in healthy plant-based diet score. Notably, no significant associations were discerned for unhealthy plant-based diet, either with all-cause mortality or cardiovascular-related mortality. Other significant findings in this study were that consumption of animal-derived foods and fruit juices were associated with a higher risk of cardiovascular-related mortality. Consumption of vegetable oils were attended by lower risk of all-cause mortality, and the Mediterranean diet score, like the healthy plant-based diet score, was generally associated with lower all-cause and cardiovascular-related mortality. To explain the health benefits of a healthy plant-based diet, the authors suggest that the antioxidant and anti-inflammatory effects of many of the components of these diets underlie the accompanying reduced risk of all-cause mortality and cardiovascular-related mortality. This important study of Delgado Velandia et al. Indicates that the health benefits of plant-based diets are not invariantly derived from such food groupings, but rather from specific plant-based dietary components. The well-accepted adage that we are what we eat would thus underscore the wisdom and importance of diets rich in vegetables, legumes, whole grains, fruits, nuts, and vegetable oil. Our first highlight this month is a brief report entitled Submaximal Angiotensin Converting Enzyme Inhibitor and Angiotensin Receptor Blocker Dosing among persons with proteinuria. It is authored by Dr. Chi D. Chu and colleagues from the University of California in San Francisco, California, and the San Francisco VA Healthcare System, San Francisco, California. Salient considerations in the management of patients with proteinuric chronic kidney disease include blood pressure control, optimizing salt and water balance, correcting metabolic complications, and retarding the rate of decline of kidney function such that the arrival of end-stage kidney disease is delayed or optimally averted. As regards the latter, there is compelling evidence that angiotensin converting enzyme inhibitors or angiotensin receptor blockers effectively delay the progression of chronic kidney disease by actions that lower blood pressure, proteinuria, and renal inflammation and fibrosis. However, as emphasized by the KDIGO 2021 Clinical Practice Guidelines for the Management of Blood Pressure in Chronic Kidney Disease, the efficacy of these agents in retarding the progression of proteinuric chronic kidney disease requires that their doses be escalated to ones maximally improved and to the extent such doses are tolerated. The rationale for this guideline is that such doses of these agents were generally employed in clinical trials that established their efficacy. The current study by Chu et al. Shows that in proteinuric chronic kidney disease, angiotensin converting enzyme inhibitors or angiotensin receptor blockers are often submaximally dosed. These authors used the database of the Optum Labs data warehouse to examine how angiotensin-converting enzyme inhibitors and angiotensin receptor blockers were dosed in over 100,000 adult patients in whom these medications were prescribed between January 1st, 2017 and December 31st, 2018. In these patients overall, less than one-third, 29.8%, were administered maximal doses of angiotensin-converting enzyme inhibitors or angiotensin receptor blockers. The authors also define criteria that may proscribe increasing the dose of angiotensin-converting enzyme inhibitors or angiotensin receptor blockers. These criteria included systolic blood pressure less than 120 millimeters of mercury, serum potassium greater than 5 milliequivalents per liter, an eGFR lower than 15 milliliters per ml, and the occurrence of acute kidney injury within the preceding year. In patients without these criteria, approximately 75,000, the percentage of patients who receive maximal doses of angiotensin-converting enzyme inhibitors or angiotensin receptor blockers marginally increased to 32.3%. Submaximal angiotensin-converting enzyme inhibitors or angiotensin receptor blocker dosing was more likely to occur in patients who were less than 40 years old, female, Hispanic, or those patients exhibiting a lower blood pressure, a higher serum creatinine, a prior episode of acute kidney injury, less albuminuria, concomitant heart failure, or the absence of diabetes. It should be noted that while some of these proscriptions against dose escalation may be absolute, for example, low blood pressure, others are relative and can be safely managed, for example, marginally elevated serum potassium, which can be controlled by increased doses of loop diuretics and/or novel potassium-binding agents. The progression of chronic kidney disease, the end-stage kidney disease, markedly increases morbidity and mortality, necessitates new therapies, and significantly alters the life of a patient with chronic kidney disease. Delaying this outcome can be achieved by angiotensin-converting enzyme inhibitors or angiotensin receptor blockers, but the full efficacy of these agents is dose-dependent. Our second highlight is an original article entitled Night Shift Work, Genetic Risk and Hypertension. It is authored by Dr. Jiahao Xiao and colleagues from Nanjing Medical University, Nanjing, China. Human biologic processes are commonly characterized by a daily rhythmicity, governed by central and peripheral circadian clocks. For example, in normotensive individuals, the blood pressure profile is characterized by a 10 to 20 millimeters of mercury decrease during nighttime, and a rise in blood pressure in the early hours of the morning, with blood pressure peaking in the afternoon. Abnormalities in this physiologic profile in blood pressure may associate with and/or predispose to hypertension and other cardiovascular diseases. The intrinsic functioning of circadian clocks is influenced by cues derived from such sources as the light-dark cycle, meal times, and social interaction. Such cues may be attenuated or lost in certain circumstances, and a salient one being night shift work. Indeed, night shift work has been linked to a variety of diseases, in part because of the attendant stress imposed on the circadian rhythmicity of biological processes. Xiao et al. Provide new insights regarding night shift work and the occurrence of hypertension. These investigators employed the large prospective observational study of the UK Biobank and classified some 230,000 of these participants in this study as day workers, shift workers but never or rarely worked the night shift, irregular shift workers including nights, and permanent night shift workers. The data demonstrate that night shift work associated with hypertension. In the three types of night shift work, a higher risk of hypertension was observed compared with day shift work, with the risk increasing as the frequency of night shift work increased. In modeling that adjusted for other factors relative to hypertension, the risk for hypertension with night shift work was still significant. Furthermore, these investigators capitalized on the availability in the UK Biobank of genotyping data, from which they derived a polygenic risk score for hypertension. Notably, the risk of hypertension was increased in permanent night shift workers with a high polygenic risk score, compared with day workers with a low polygenic risk score. This important study demonstrates that there is an increase for hypertension in night shift workers, a risk that itself may be conditioned by genetic factors. You can access these highlights and editor's choice articles free of charge during the entire month of November. Please visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, where you'll find links to our social media by clicking the buttons at the bottom of the home page, or to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights, and our Mayo Clinic Proceedings 60 seconds video article synopses. Our website also includes our Mayo Clinic Proceedings issue summary and author insight podcast recordings, which are available from our website on the home page as well as through iTunes. You will also find our online-only features and many news stories posted in the news from the editor carousel on our website homepage that are based on articles published in Mayo Clinic Proceedings. And finally, you'll see other free content as well as articles published online in press. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings. We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.